Let's begin with our fifth and final section, and in this final section we will talk about the tumor localization, how we can localize the tumor, and then what are the different diagnostic tests for tumor like localization, what specific anti-tumor treatments, and then peptide receptor radionuclide therapy. Tumor localization, curative or cytoreductive. It's important for the classification and the staging of the tumor. It's very important we should know the location of the tumor, site of the primary tumor. It's used for the staging and classification to find out at what stage the tumor is, how better would be the prognosis or poor will be the prognosis, and for the curative or cytoreductive treatment options we should know the tumor localization. The tumor localization methods which are used, we have the CT and MRI, cross-sectional imaging, and in the cross-sectional imaging we have CT scan and MRI. Selective angiography, somatostatin receptor scintigraphy, positron emission tomography, endoscopic ultrasounds, and measurement of venous hormonal gradients. So all these are the different methods for localization of the tumor site. We have CT, MRI, angiography, PET, SRS, which is somatostatin receptor scintigraphy, endoscopic ultrasound, and measuring the level of the hormone. So that's all the methods used for the localization of the tumor. Diagnosis is by the chest radiographs also, CT, MRI, rectal, duodenal, colonic, gastric endoscopies, insulinomas and gastrinomas usually be undetectable by cross-sectional imaging. So these are again, chest x-ray can also be used along with the CT, MRI, and then endoscopies, especially for gastrointestinal tumors. Another methods of diagnosis for the pancreatic and gastrointestinal neuroendocrine tumors is they overexpress the somatostatin receptors. Overexpression of the somatostatin receptors, for which we use different drugs, is also the diagnostic step for the neuroendocrine tumors. Radio-labeled octreotide, which binds to the SST2 and somatostatin receptor 2 and 5, which are the major receptors. They have high affinity for these receptors. Used for treating tumors and localization of neuroendocrine tumors. Endoscopic ultrasound with cytologic evaluation, which distinguish neuroendocrine pancreatic tumor from the non-functional, NF is non-functional neuroendocrine tumors from pancreatic adenocarcinomas and another pancreatic tumor. So endoscopic ultrasound is performed with cytological, with evaluation of the cells that will help to differentiate non-functional type of tumor from the adenocarcinoma and another pancreatic tumors. So all these are different diagnostic tests we are talking about for the tumor localization, which is very important to find out the classification, staging of the tumor, and also different treatment options we can use for the treatment of the tumor. Occult small intestinal neuroendocrine tumors, they are detected by double balloon endoscopy and capsule endoscopy. So these are the methods used for the small intestinal tumors. Insulinomas. Insulinomas, in case of insulinomas, how we can do the tumor localization. Insulinomas overexpress receptors GLP type 1, radiolabeled GLP-1 analogs are used to detect the occult type of insulinomas. Occult is hidden, which is not visible to the naked eye. So if occult type of insulinomas are present, we can use the GLP-1 analogs. Measurement of hormonal gradient, in case of insulinomas, measurement of the insulin. Other imaging techniques are usually negative in insulinomas. Intra-arterial calcium test can also be used for diagnosis of insulinoma. Other techniques we can use like PET, positron emission tomography by the 18 fluorodopa, and also with 11 cis 5 hydroxytryptophan in ATP in patients. So these are used for positive emission tomography. Use of hybrid scanners like CT and SRS can also be used. Then advanced disease, in metastatic disease, how we can do the localization treatment is by the cytoreductive surgery. So advanced disease, if it is metastasized to distant areas like liver, cytoreductive surgery, radiofrequency ablation, chemotherapy, somatostatin analogs, interferon alpha therapy, hepatic embolization or chemoembolization, molecular target therapy, radiotherapy with radio-labeled beads, microspheres, peptide radioreceptor therapy. So all these are different treatment options for the treatment of neuroendocrine tumors which are already metastasized to the other areas. We can use different treatment options. And ultimately, liver transplantation if required. Then specific anti-tumor treatments. Specific anti-tumor treatment, we have cytoreductive surgery if tumor is resectable. So if tumor thought resectable, then we can do cytoreductive surgery. Radiofrequency ablation, if a neuroendocrine tumor liver metastasis is present, then we can use radiofrequency ablation, and if it is limited in number and size. Chemotherapy is for advanced type of neuroendocrine tumors. 2 and 3 drug combinations are used. Usually the combinations are streptozotocin and doxorubicin with or without 5-fluorouracil. Temozolomide with capacitabine and temozolomide can be used as the chemotherapeutic agent. Then we have another cisplatin-based regimen with etoposide. So all these are different chemotherapeutic drugs that can be used usually in the combination of 2 and 3 drugs. Then long-acting somatostatin analog, octreotide and lanreotide can also be used for specific anti-tumor treatment. And then finally also the use of alpha interferon alpha. This mainly control the hormonal excess symptoms of the patient with the neuroendocrine tumor. Some other specific anti-tumor treatments: selective internal radiation therapy using the yttrium-90 glass or resin microspheres, evaluation for vascular shunting, and pre-treatment angiogram. So these are all specific anti-tumor treatment. Then we have MRO inhibitor, MTOR inhibitors, which is the everolimus. Tyrosine kinase inhibitor, which is sunitinib, and anti-proliferative activity in neuroendocrine tumors. Liver transplantation is abandoned for most metastatic tumor, which is not used or not tried, is abandoned or left. So these are also some specific anti-tumor treatment. We have selective internal radiation therapy, MTOR inhibitors, tyrosine kinase inhibitor, and finally liver transplantation, but it's abandoned in the metastatic tumors because it's metastasized to the other areas also besides the liver, other organs, so the liver transplantation may be not effective in these cases. Peptide receptor radionuclide therapy. It is radio-labeled somatostatin analogs are used, targeting of cytotoxic radio-labeled ligands. Radioactive analogs used are the DTPA octreotide, 90 yttrium, and then we can also use lutetium coupled analog. So all these are different, the peptide receptor radionuclear therapy used for, in which we can use radioactive analogs like octreotide, 90 yttrium and lutetium coupled analog. That was all about the tumor localization and how we can localize the tumor. Localization will be effective for the treatment options and also for classification and staging of the tumor. And then we also discussed about specific anti-tumor treatment and then what are the different drugs that can be tried for specific anti-tumor treatment. So that concludes our today's lecture, which was about pancreatic neuroendocrine tumors. Thank you for watching sqadia.com.